Hello, I'm Claire Francomano, and it's my great pleasure to be here with you today to discuss the hereditary disorders of connective tissue with an emphasis on the Ehlers-Danlos Syndromes. My thanks to Sandy Smink and to all the organizers of this conference for your kind invitation. The Ehlers-Danlos Syndromes sit on the spectrum of joint hypermobility, which was described by Marco Castori and his colleagues in 2017. The spectrum of joint hypermobility ranges from asymptomatic joint hypermobility through symptomatic joint hypermobility, which we call the hypermobility spectrum disorders, or HSDs, through to hypermobile Ehlers-Danlos syndrome on the extreme end of the spectrum. And asymptomatic joint hypermobility and the hypermobility spectrum disorders may represent generalized joint hypermobility, or GJH, peripheral hypermobility, which is limited to the small joints in the hands and feet, or localized joint hypermobility, which includes just a single joint or body part. The Ehlers-Danlos syndromes constitute, now there are 14 different types that we recognize. And of those 14 types, we know the underlying pathology and genes for 13 of those types. We divide the Ehlers-Danlos syndromes into disorders of fibrillar collagen, primary structure and processing, folding and cross-linking, the disorders of structure and function of the myomatrix, which is the interface between muscle and the extracellular matrix. There's a group of disorders which represent glycosaminoglycan biosynthesis disorders. And then there are disorders that are linked to aberrant intracellular processes. Finally, the periodontal type of Ehlers-Danlos syndrome is unique in that it represents a disorder of the complement pathway. And I really like this daisy representation that Joanna Amberger and her colleagues at Hopkins came up with in 2018, which represents the different types of Ehlers-Danlos syndrome and the genes that underlie the different types. And you will notice in red the word unknown for the pedal for the hypermobile type, because that is the one type of Ehlers-Danlos syndrome for which we still do not really know the underlying gene or genes. Now, how do we diagnose the Ehlers-Danlos syndromes? We are now using a set of diagnostic criteria which were published in 2017 in the American Journal of Medical Genetics. And the papers describing these diagnostic criteria are available at the Ehlers-Danlos Society website, and the journal has made them available at no cost because there has been such a great interest in them since they were published. And also on the Ehlers-Danlos Society website is a checklist for the diagnosis of hypermobile EDS, which, as I mentioned, is the most common type of Ehlers-Danlos syndrome. And there are three criteria for diagnosing hypermobile Ehlers-Danlos syndrome. The first is that of generalized joint hypermobility, and we use a scale called the Beighton scale to assess for generalized joint hypermobility. The Beighton scale is a 9-point scale. It looks for hypermobility at the base of the fifth finger, at the wrist, the elbows, the knees, and in the spine. And we need a score of 6 or more in prepubertal children and adolescents to call generalized joint hypermobility, greater than or equal to 5 in men and women up to age 50. And for people over age 50, a score of 4 or more will qualify for generalized joint hypermobility. Now, when the committee was considering the diagnosis of hypermobile EDS, they included a five-point questionnaire to augment the Beighton score assessment for generalized joint hypermobility. So we ask these 5 questions. If a person is right on the cusp of meeting the criteria for generalized joint hypermobility, if they have 2 or more affirmative answers to these 5 questions, then we can give them an extra point and sometimes push them over the finish line to achieve a diagnosis of generalized joint hypermobility. And these questions are, can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? And finally, do you consider yourself to be double jointed? So 2 positive answers to any of those 5 questions will get you an extra point for the Beighton score. Now, the second criteria for hypermobile Ehlers-Danlos syndrome is that a person must have 2 out of the 3 features in criterion 2. So feature A is this list of, so we might consider them to be systemic findings, including unusually soft or velvety skin, mild skin hyperextensibility, unexplained strii or stretch marks that were not associated with weight gain or pregnancy, bilateral piezogenic papules on the heels. These are little bumps that poke out between the connective tissue when you're putting all your weight on your heels, recurrent or multiple abdominal hernias, atrophic scarring involving at least 2 sites, and without the really very, very severe papyraceous scars that we see in the classical type of Ehlers-Danlos syndrome. Pelvic floor, rectal, and or uterine prolapse, dental crowding and a high narrow palate, arachnodactyly or very long thin fingers, an arm span to height ratio of greater than or equal to 1.05, mitral valve prolapse on echocardiogram, and finally, aortic root dilatation with a Z-score of greater than or equal to +2. So we total up the number of features here, and if there are 5 or more present, we say that the person meets feature A of criteria 2. Feature B is a positive family history with 1 or more first-degree relatives independently meeting the current criteria for hypermobile EDS. And feature C, and the person must have at least 1 of these, with either musculoskeletal pain in 2 or more limbs recurring daily for at least 3 months, chronic widespread pain for greater than or equal to 3 months, and recurrent joint dislocations or frank joint instability in the absence of trauma. So under criterion 2, if 2 of those 3 features, A, B, and C, are present, then we say the person meets criteria 2. And finally, in criteria 3, we're basically saying we have to do our due diligence to be sure that we've considered fully a differential diagnosis and we've excluded all other possible explanations for the person's phenotype that we're seeing in front of us. So we want to make sure they don't have unusual skin fragility, which should prompt consideration of other types of Ehlers-Danlos syndrome. And we want to exclude other heritable and acquired connective tissue disorders, and also alternative diagnoses that may also include joint hypermobility. For example, if they have, if the person might have hypotonia. So we want to really be thinking that we've done our due diligence and considered a full differential diagnosis. So what are some of those other hereditary disorders of connective tissue that we should consider? I did a search on OMIM today just to look. When I put in joint hypermobility, I got back 1,599 entries in OMIM. So there are very many syndromes and genes associated with joint hypermobility. But really, the three that I really would want to consider in a differential are Marfan syndrome, Stickler syndrome, fibromuscular dysplasia, and cutis laxa. So, and I asked about these features both in the personal history for my patient, but also in their family history. Is there any personal or family history of aortic root aneurysm or rupture? Any dislocation of the ocular lenses or spontaneous pneumothorax in anyone? Is there premature osteoarthritis, which is often seen in Stickler syndrome, or premature hearing loss, retinal detachments? These are things that should be red flags to make us think about other hereditary disorders of connective tissue. In fibromuscular dysplasia, there's a nutcracker appearance to the arteries on vascular imaging. And in cutis laxa, the skin is very loose and often redundant. And when you pull on it, it returns very slowly to the original shape when stretched. So if you see any of these features in the personal or family history of your patient, it's definitely worthwhile to think about these other hereditary disorders of connective tissue. Now, moving on to the less common forms of Ehlers-Danlos syndrome, I think the classical type of EDS is probably the next most frequent type, next to the hypermobile type. And in the classical type of Ehlers-Danlos syndrome, we see we have two major criteria, which are skin hyperextensibility and atrophic scarring, and then generalized joint hypermobility. And there's a list of minor criteria that include easy bruising, soft, doughy skin, skin fragility, which may split very easily with only very minor trauma. There may be molluscoid pseudotumors or subcutaneous spheroids under the skin, hernia or a history of hernia, epicanthal folds, and you might see complications of joint hypermobility, including sprains and subluxations, pain, and flexible flat foot. And then also a family history of a first-degree relative who meets clinical criteria is considered to be one of the minor criteria for this condition. So according to the 2017 criteria for diagnosis of classical Ehlers-Danlos syndrome, we want to see the first major criteria is required. So we must see skin hyperextensibility and atrophic scarring. And then in addition to that, we need to have either the second major criteria, which is that of generalized joint hypermobility, or 3 of the 8 minor criteria. And you can establish a clinical diagnosis of classical EDS in that way. So the skin hyperextensibility in the classical type is much more dramatic than we usually expect to see in the hypermobile type. It really pulls away. We use a criteria of at least 3 centimeters. And in addition, the scarring is absolutely typical for the classical type of Ehlers-Danlos syndrome. We look along the shins to see whether or not there is this bruising type appearance to the scars, and also these what we call hemosiderotic scars, where it looks like there's been deposition of hemosiderin underneath the skin. And this is another illustration of the Beighton score, again illustrating how we look at the flexibility at the wrist at the metacarpal phalangeal joint of the fifth fingers, the knees, the elbows, and flexibility in the spine. So for classical Ehlers-Danlos syndrome, we look for identification of a pathogenic variant in COL5A1 or COL5A2 to confirm the diagnosis of this condition. These are the genes that encode type 5 collagen, and in more than 90% of cases that are diagnosed clinically with the classical type of Ehlers-Danlos syndrome, we will find a variant in COL5A1 or COL5A2. Moving on to the vascular type of Ehlers-Danlos syndrome, in this condition, the major criteria include a family history of vascular EDS with a documented causative variant in COL3A1. This is the gene that encodes type 3 collagen. Arterial rupture at a young age, by young meaning probably less than 40. Spontaneous sigmoid colon perforation in the absence of known diverticular disease or other bowel pathology. A uterine rupture during the third trimester of pregnancy in the absence of a previous C-section and or severe peripartum perineum tears. And finally, a cavernous carotid sinus fistula formation in the absence of trauma. And there's a long list of minor criteria for the vascular type of Ehlers-Danlos syndrome as well. But truly, to make a diagnosis of vascular Ehlers-Danlos syndrome, you want to think about these minimal criteria that are suggestive for VEDS. And they include the family history of the disorder, arterial rupture or dissection in individuals less than 40 years of age, unexplained sigmoid colon rupture, or spontaneous pneumothorax. And to confirm the diagnosis of vascular EDS, we look for a pathogenic variant in COL3A1, which encodes type 3 collagen. There is a somewhat typical appearance to the vascular Ehlers-Danlos syndrome, and if it is present, can sometimes help in the identification of this condition. Typically what we consider to be a slightly triangular face with very prominent eyes and thin lips, but often this typical face is not present, so we can't rely on its presence to point us in the right direction for that diagnosis. Okay, so we've considered 3 types. That leaves 11 more, which are the rarer types of the Ehlers-Danlos syndrome. And all of these were really lovely, laid out very well, in a lovely way, in this paper on the Ehlers-Danlos syndromes of the rare types, with Angela Brady as the first author. And this paper also is available in the American Journal of Medical Genetics issue, which is available through the Ehlers-Danlos Society website. So I'm not going to take you through all of those 11 types that we haven't considered yet, but I will mention a few of them. The arthrochalasia type of Ehlers-Danlos syndrome has severe generalized joint hypermobility, congenital bilateral hip dislocations, and recurrent subluxations and dislocations of both small and large joints. And this condition is caused by variants in COL1A1 and COL1A2. You can see some foot deformities here that may be seen in the arthrochalasia type as well. The kyphoscoliotic type of Ehlers-Danlos syndrome, it presents with severe and progressive kyphoscoliosis. Joint hypermobility is present, and there are joint subluxations and dislocations. The skin has hyperextensibility, fragility, easy bruising, and atrophic scarring. And this condition is an autosomal recessive disorder that's caused by variants in the PLOD1 gene, which encodes lysyl hydroxylase, the enzyme lysyl hydroxylase. And finally, brittle cornea syndrome. These patients have a somewhat Marfanoid-looking appearance sometimes. They have joint hypermobility, which may be limited to the small joints. You might not see generalized joint hypermobility in this condition. There are joint subluxations and dislocations, and hip dysplasia may be present. These patients also develop kyphoscoliosis and foot deformities. They have soft, velvety skin and translucent skin, but typically no atrophic scarring. And the hallmark of this condition is the fragility of the ocular globe. So there's a high risk of corneal perforation and ocular rupture, keratoconus, high myopia, and very typically quite blue appearance to the sclerae. And about 30% of patients with brittle cornea syndrome will develop hearing loss. So a few hallmarks when you're looking at somebody who has joint hypermobility and you're kind of wondering which type, is this the hypermobile type, or should we be looking more deeply for one of the other rarer types? If you're seeing severe congenital joint laxity, the really, really extreme congenital joint laxity, arthrochalasia type is under consideration. With congenital hip dislocations, we would also think about the arthrochalasia type. Congenital hip dysplasia is more common in the kyphoscoliotic type. If the patient has severe aortic or mitral valve disease, think about the cardiovalvular type. And if it's a classical picture, but really has some vascular fragility as well, there is a classical type due to COL1A1 variants that does present with vascular fragility and a classical type appearance. Patients with extreme skin fragility should prompt consideration of the dermatosparaxis type or the classical type. And if there is kyphoscoliosis and short stature, the differential would include the kyphoscoliotic type, the spondylodysplastic type, and the musculocontractural type. And the fact of the matter is that these days we rarely do testing for a single gene anymore. We're doing panels of testing whenever we're thinking along a differential such as this. So there are a number of different laboratories now that offer panels that have all the known genes to cause the various different types of Ehlers-Danlos syndrome. And if you see any one of these features, it's worthwhile to do that kind of panel testing to make sure you're not missing one of the rarer forms. So Sandy also asked me to say just a few words about when to think about CSF leaks in patients with hereditary disorders of connective tissue. And I know you're hearing a lot about CSF leaks from experts today. So I'll just say these few couple of things that I've heard from patients of mine who've experienced CSF leaks. So the nature of the headache just changes. It goes from, often patients will have been experiencing high pressure headaches prior to the development of a CSF leak. And that feeling of extreme pressure in the head and pressure behind the eyes changes, and it doesn't feel so much like intense pressure anymore, but almost like a pulling in the back of the head. And the positional nature of the headache changes. Often people are really unable to tolerate being upright for even more than 10 or 15 minutes, and they have to lie down. If the person has had a lumbar puncture and they start developing a headache that's typical of hypotension, cerebral hypotension, one should think about a CSF leak. And if they've had any surgical procedure involving the dura, such as spinal anesthesia, and then a couple of days later, they start developing that typical headache, definitely think about CSF leaks. And of course, if they have any unusual drainage from their nose or their ears, we think about the CSF leak. But I'm going to leave it to the experts to tell you much more about that today. So again, I'd like to thank the ILC Foundation for inviting me here today. My thanks to the Ehlers-Danlos Society for their support and the International Ehlers-Danlos Society Consortium for their support and wonderful collegiality, and also, and really predominantly, to my patients and their families for allowing me to share their journey with them. And thank you very much for your attention.